In 2026, researchers looked at thousands of pelvic surgeries and found something that, honestly, it kind of fundamentally breaks the standard rule of modern medicine.
It really does. It forces a complete reevaluation of, well, how we handle pelvic organ prolapse.
Right. Because they basically discovered that a surgical procedure invented, like before the discovery of penicillin, is actually up to 5 times more effective than our cutting edge modern techniques.
Yeah, we're looking at clinical outcomes where simply dusting off an archival medical text, yields vastly superior biomechanical durability compared to the current gold standard.
It is wild. So to explore this, we are diving into a massive 2026 comprehensive systematic and scoping review. It was published in Acta Obstetricia et Gynecologica Scandinavica.
Authored by Sophia Lasoi and her team, yeah.
Exactly. And this review, it aggregates all this data on the clinical, the financial, and the quality of life outcomes of something called the Manchester procedure. And the mission of this deep dive today is to really dissect the anatomy and the data behind this review and to help you understand why newer technology in the operating room doesn't automatically translate to better physiological outcomes.
I mean, whether you are a clinician looking at the shifting data on pelvic floor reconstruction, or maybe you're someone navigating gynecological health decisions for yourself, or even just a learner fascinated by the biomechanics of the human body.
Yeah.
This data fundamentally shifts the paradigm of surgical intervention.
Okay, let's unpack this. We already know the baseline statistics regarding pelvic organ prolapse, or POP. Upwards of 40% of women over 45 experience some degree of prolapse.
Right, with about 1 in 5 ultimately undergoing surgery.
Yeah, but the statistic that, it drives this entire review is the recurrence rate, because up to 30% of patients require a second surgery because the initial structural fix it fails.
And that failure rate is exactly what has driven the surgical community to constantly chase new solutions, Historically, the dominant approach for apical prolapse has been the vaginal hysterectomy.
Removing the uterus completely.
Right. Removing it was viewed as the most definitive way to resolve the mechanical descent, while at the same time eliminating the risk of uterine or cervical malignancies down the line.
Which, the logic seems pretty straightforward on the surface, right? If the organ is falling out, just remove the organ.
Sure. It makes sense intuitively.
But the review highlights how that approach fundamentally misunderstands the biomechanics of the pelvic floor. The uterus isn't just like sitting passively in the pelvis. It acts as this really critical anchor point.
Exactly. It functions much like the keystone in an architectural arch. The uterus, or specifically the pericervical ring, is this central hub where the uterosacral and cardinal ligament complexes all converge.
Wow, okay.
We refer to this as level life support. So when you perform a vaginal hysterectomy, you are essentially severing those central attachments.
Yeah. You're taking out the load-bearing hub.
You are.
So wait, the old logic was basically like tearing down an entire house just because the foundation was a little saggy. No wonder patients are pushing back.
If we connect this to the bigger picture, that patient pushback is huge. Women have increasingly been advocating for uterus-preserving options.
Right, because of personal preference or a sexual function concern?
Exactly, and a desire to avoid the cascading structural failures of a hysterectomy. Because the data shows that removing the uterus significantly increases the risk of subsequent prolapse in other compartments.
Like the anterior compartment, right?
Yes. Without that central pericervical ring holding the tension, the surrounding structures, like the bladder and the vaginal vault itself, they basically lose their suspension and begin to collapse under intra-abdominal pressure.
Oh, man.
You also see a marked increase in stress urinary incontinence following vaginal hysterectomy, because the extensive dissection required to get the entire uterus out often disrupts the local autonomic nerve plexuses and the fascia that support the urethra.
So the surgery fixes one problem but kind of causes a bunch of others.
Right, and that patient advocacy for keeping the uterus, combined with those dismal recurrence rates of modern alternatives, that is what sent surgeons looking backward, to the Manchester procedure.
Okay, so let's talk about the Manchester procedure, because it offers a very different anatomical approach. Rather than removing the keystone, it reinforces it.
It does. The procedure involves amputating the elongated portion of the uterine cervix while completely preserving the uterine body.
Okay.
The crucial step, though, is the extraperitoneal plication of the uterosacral ligaments.
Wait, hold on. Let's break down the mechanics of that plication, because that is where the structural integrity actually comes from, right? Plication basically means folding and tightening.
Exactly. And doing it extraperitoneally means the surgeon never actually enters the main abdominal cavity.
Oh, wow.
Yeah, they can isolate these bands of tissue, shorten them to remove the laxity, and suture them right to the newly shortened cervix.
So instead of removing the whole dress, you're essentially like taking up the hemline and tightening the suspenders to hold everything securely in place.
That is a perfect way to visualize it.
Yeah.
You are reestablishing the natural anatomical axis of the vagina. You utilize the patient's own native tissue, pulling the preserved uterine body back upward and backward toward the sacrum,
Right where it's supposed to be.
exactly where it is supposed to sit.
It's essentially taking the existing biological suspension cables, pulling the slack out of them, and anchoring them back to the center weight.
Right. And then there is the final step, the Sturmdorf suture, which the review mentions as this really key part of the procedure's success.
Right, because this isn't just about closing a wound.
No, the Sturmdorf suture is a brilliant piece of surgical engineering. After amputating the lower cervix, you are left with this raw stromal surface.
Okay.
The Sturmdorf technique involves taking a bite of the vaginal mucosa, passing the suture deep into the cervical stroma, and bringing it out through the cervical canal. When you tie it down, it perfectly inverts the vaginal mucosa over the raw stump, effectively tucking the edges inward.
Which prevents cervical stenosis, because if you just left it to heal or closed it flat, the scar tissue could contract and block the cervical canal entirely, right?
Precisely. And that would trap menstrual fluid and cause severe complications.
Oh, that sounds awful.
Yeah, so the Sturmdorf suture maintains the opening, the itas, while simultaneously adding bulk and structural reinforcement to the top of the vagina.
Okay, so with that biomechanical foundation established, let's look at how it actually performs in the real world. Because Alyssa Wee's team analyzed 19 rigorous studies, placing the Manchester procedure head-to-head against vaginal hysterectomy and the modern alternative, sacrospinous hysteropexy, or SSHP.
Yes.
And the Danish nationwide cohort study by Husby and colleagues is really compelling here. They analyzed over 6,800 women.
A massive sample size.
Huge. And the 5-year reoperation rate for the Manchester procedure was just 7%. For the vaginal hysterectomy, it was 11%.
And that 4% absolute difference, it translates to hundreds of women avoiding a second major surgery.
Here's where it gets really interesting, though. The comparison against the modern sacrospinous hysteropexy, because that data is truly disruptive.
It is. A nationwide register study found that the reoperation risk was 5 times higher after SSHP compared to the Manchester procedure.
5 times?
Yeah. The 5-year reoperation rate was an astonishing 32% for SSHP versus just that 7% for MP.
That is just, wow. And a 2023 multi-center randomized controlled trial mirrored this, showing composite success rates of 87.3% for MP and only 77% for SSHP.
We have to look at the anatomy to understand why this modern SSHP technique fails at such an alarming rate compared to a procedure from the early 1900s.
Right. Why is the old one better?
Well, sacrospinous hysteropexy involves using stitches, or sometimes synthetic mesh, to anchor the cervix unilaterally or bilaterally to the sacrospinous ligament deep in the pelvis.
Which creates an entirely unnatural vector of tension, right? Because when you anchor the apex to the sacrospinous ligament, you are pulling the top of the vagina backward and off to the side.
Exactly. Down and to the side, it retroverts the uterus and completely changes the angle of the vaginal canal.
That alteration of the axis has to be the critical flaw. Right. By pulling the apex so far back, you basically expose the entire anterior vaginal wall to the direct downward force of intra-abdominal pressure. Every time the patient coughs, lifts, or strains,
Yes, the pressure hits it directly.
it's like pulling the center pole of a tent off to one side. You leave the entire front canvas completely unsupported against the wind.
That's exactly what happens.
Yeah.
And that is why SSHP patients present with such high rates of secondary cystocele or bladder prolapse.
Ah, okay.
The Manchester procedure, by contrast, pulls the uterus straight up along its natural physiological axis, so it distributes the pressure evenly across the pelvic floor.
And that maintenance of natural anatomy also translates directly into the actual time in the operating room, right? The perioperative benefits.
Yes. Because the Manchester procedure operates extraperitoneally and avoids all that deep pelvic dissection required for both vaginal hysterectomy and SSHP, the operative metrics are vastly superior.
The reduction in surgical trauma is significant. Like, the studies in the review demonstrated substantially lower blood loss for the Manchester procedure, One trial recorded an average blood loss of 44.6 milliliters for MP, compared to over 100 milliliters for the vaginal hysterectomy.
Right, because when you perform a vaginal hysterectomy, you must open the peritoneum and systematically tie off and cut highly vascular pedicles, most notably the uterine arteries.
Which bleed a lot.
Exactly.
Right.
By preserving the uterine body and staying extraperitoneal, the Manchester procedure avoids those major vascular bundles entirely.
And the operative times reflect that efficiency, too. The data shows an average of 62 minutes for the Manichet procedure versus 78 minutes for a vaginal hysterectomy.
It's just faster.
Yeah. And across all the procedures analyzed, severe organ injuries, like bladder or bowel lesions, they were incredibly rare, hovering around 1% or less.
The preservation of the local anatomy also pays dividends when we look at lower urinary tract symptoms. The review analyzed postoperative stress, urinary incontinence, and urinary retention.
Okay, the surgery is faster, less bloody, and holds up better over time. But what about the patient's daily life afterward? Does fixing the prolapse accidentally cause other plumbing issues?
Well, while results varied slightly across the specific trials, the Manchester procedure consistently matched or outperformed vaginal hysterectomy. One RCT actually found a 0% risk of postoperative stress urinary incontinence for MP.
0%.
Yep, compared to an 8.8% risk following VH.
Wow.
This goes back to what we discussed about the autonomic nerve plexuses. Because the surgeon isn't dissecting high up into the broad ligament or disrupting the fascia surrounding the bladder neck, the innervation has supported the urethra remain completely intact.
And the quality of life metrics naturally follow that physiological preservation. Because across multiple validated scoring systems, patients experience profound, statistically significant improvements in their quality of life.
Yeah, with no statistical difference between MP and VH in those quality of life improvements.
So let's pivot, because we have to address the most obvious historical objection to preserving the uterus.
The cancer risk.
Right, the cancer question.
Okay.
Because if you leave the uterus and part of the cervix in the body, aren't you leaving a ticking time bomb for cancer? Isn't that exactly why they preferred hysterectomies?
It's a very valid concern, and, it requires robust epidemiological data to refute. But what's fascinating here is how the review uses massive Danish cohort studies that specifically tracked long-term cancer incidence to answer this.
Right.
They compared over 23,000 Manchester procedure patients to 51,000 patients who had a different minor pelvic floor repair following them over a 13-year period.
I mean, that sample size is practically population-level data. And the results completely dismantle that historical assumption. There was zero difference in the risk of developing endometrial cancer between the two groups.
Zero. But the truly fascinating data point is regarding cervical cancer.
Yeah, this part blew my mind.
The Manchester procedure was actually associated with a reduced risk of a subsequent cervical cancer diagnosis. The adjusted hazard ratio was 0.567.
Meaning patients who had the Manchester procedure were nearly half as likely to develop cervical cancer compared to the control group.
Exactly.
We have to explain the mechanism behind that, because it is just this brilliant byproduct of the surgical anatomy. Cervical cancer does not just spontaneously erupt anywhere on the cervix, right? The vast majority of cases originate in a very specific area called the transformation zone.
Yes, the squamocolumnar junction. That is the area where the squamous epithelium of the outer cervix meets the glandular columnar epithelium of the cervical canal. It is an area of high cellular turnover, so it's uniquely vulnerable to HPV infection and subsequent malignant transformation.
Right. And the first step of the Manchester procedure is amputating the lower portion of the cervix to reduce the prolapse volume. So by pure anatomical coincidence, amputating that specific distal portion physically removes the entire transformation zone.
It does. You are inadvertently performing an aggressive prophylactic excision of the exact tissue where cervical cancer originates,
leaving behind only the upper cervical stroma and the uterine body, which have an incredibly low baseline risk of malignancy.
Right. It provides profound oncological safety without requiring the trauma of a full hysterectomy.
Which is amazing. And this also plays a direct role in intimacy and postoperative sexual function, which the scoping review examined too.
Yes, they looked at that through the PICU-12 scoring system and other validated questionnaires.
So, dyspareunia, or pain during intercourse, is obviously a major metric for pelvic floor surgeries. The review found that postoperative dyspareunia occurred at comparable rates between MP and VH, hovering around 18 to 20%.
However, When looking at the overall PI's Q12 scores, which measure broader aspects of sexual function and satisfaction, over 50% of women experienced a measurable improvement in sexual dysfunction following the Manchester procedure.
Over half.
Yeah. Preserving the vaginal length and avoiding the apical scarring that you get with a vaginal cuff closure during a hysterectomy, that likely contributes a lot to that functional improvement.
Okay, I have to play the skeptic here.
Go for it.
Because it's safer, it's faster, it preserves the uterus, it doesn't increase cancer risk, and it improves sex. I refuse to believe it's perfect. What is the catch?
Well, there is a catch. The absolute critical clinical limitation is pregnancy.
Ah.
Because the procedure fundamentally alters the structural integrity of the cervix through amputation,
Yeah.
it severely compromises the organ's ability to maintain a pregnancy.
Right, because the cervix isn't just a passageway. It's this dynamic fibromuscular ring that must stay rigidly closed to retain the mucus plug and, resist the massive hydrostatic pressure of a growing amniotic sac.
Exactly. When you amputate the distal portion and disrupt that fibromuscular ring, you induce profound cervical insufficiency.
The biomechanics simply do not support a growing fetus.
They don't. And the data on post-procedure pregnancies is incredibly sparse for exactly this reason. The review located only 3 documented full-term pregnancies following a Manchester procedure.
Wow, just 3.
Yeah. And more importantly, they cite a meta-analysis highlighting a 42.9% rate of adverse obstetric outcomes. That includes mid-trimester miscarriage and premature rupture in membranes.
That is huge. Therefore, the absolute clinical consensus in the literature is that the Manchester procedure is strictly contraindicated for any patient who desires future fertility. It is exclusively an option for women who have definitively completed childbearing.
Yes, that is the hard line. But provided the patient meets that specific criterion, the advantages extend beyond just the clinical and physiological.
Right.
The final dimension this review explores is the economic impact, which is increasingly critical in modern healthcare systems.
The financial plot twist. Because this analysis aligns perfectly with the clinical data. I mean, think about it. When you reduce operative time and drastically cut the reoperation rate, the systemic costs have to plummet.
They do. Husby's 2018 activity-based costing analysis demonstrated that hospital costs were roughly 1/3 lower for the Manchester procedure compared to a vaginal hysterectomy.
Like 2,300 euros versus 3,500.
Exactly. And when evaluated against the modern sacrospinous hysteropexy, a 2025 randomized controlled trial by Shilton and colleagues provided a really comprehensive longitudinal view.
They calculated the total societal costs over a 24-month period, right?
Right.
Incorporating the initial surgery, management of complications, readmissions, and lost productivity.
Right. And the Manchester procedure proved nearly 15% cheaper overall. Roughly 8,400 euros compared to almost 9,900 for the modern SSHP.
So the modern approach isn't just failing structurally at a higher rate, it is placing a significantly higher financial burden on both the patient and the healthcare system.
It creates a very compelling argument for systemic adoption. We have a procedure that preserves native anatomy, it aligns with patient preferences for uterine preservation, it delivers superior biomechanical durability, and does so at a lower systemic cost.
So to summarize the findings of this 2026 deep dive, the Manchester procedure, utilizing that extraperitoneal uterosacral plication and cervical amputation, it provides a structurally superior repair for apical prolapse compared to both the historical standard of vaginal hysterectomy and the modern sacrospinous hysteropexy.
Absolutely.
It offers a 5-year reoperation rate as low as 7%, reduces operative trauma, inadvertently provides prophylaxis against cervical cancer by removing that transformation zone, and reduces overall societal healthcare costs.
All bound by the single clinical absolute that the patient must have completed childbearing.
Right.
And, the most profound takeaway here for anyone engaging with medical literature or just making healthcare decisions for themselves is that efficacy is not strictly linear with time.
So true.
We often default to this assumption that newer surgical meshes, complex modern fixation techniques, or just total organ removal represent the pinnacle of our capabilities.
Right. Newer must be better.
Exactly. But rigorous, large-scale data proves that respecting the native biomechanics of the pelvis, using an older, frankly, more elegant technique, yields vastly superior long-term results.
It demands a highly critical eye toward how we define a gold standard in medicine, honestly.
It does, advocating for tailored, anatomically respectful procedures. Rather than just defaulting to the newest technological trend or the most aggressive intervention, it has real, tangible impacts on physiological function and overall recovery for you as the patient.
Which leaves you with a final thought to mull over. If a highly effective, anatomically sound procedure like the Manchester surgery was essentially sidelined for decades by a cultural medical trend toward total hysterectomies, only to be gloriously vindicated by massive cohort studies today, what other outdated medical procedures or therapies are currently sitting quietly in the archives, just waiting for the right data to prove we never should have abandoned them? Thank you so much for joining us on this deep dive.